Prima della conclusione, il professor Abdul Jamil Tajik della Mayo Clinic Chair, International Committee, American College of Cardiology, terrà la Open Lecture dal titolo Echocardiography, the Old, the New, the Future.
Chancellor of the University of Modena, Dean of Medical School, Director of the Hospital, and the Chief of Cardiology, Professor Maria Grazia Modena, distinguished faculty, and ladies and gentlemen. It is indeed my great privilege and greatest honor to be here with you and be honored to give this opening lecture of what I consider one of the most innovative conferences where we are going to be discussing going from the endothelium to the balloon. I thank Professor Modena for inviting me and my colleague Jim Seward from Mayo Clinic. We have known Professor Modena for 25 years or so. We are good friends, our families are good friends, and I would like to indicate that Mayo Clinic is very proud, as you all are, of her achievements as the Professor of Cardiology, Chairwoman of the department, and the first president, woman president of the Italian Cardiac Society. So thank you for this privilege and honor to be with you and to share some thoughts regarding one of the established imaging modality, which is echocardiography, is past, is present, and what lies in the future. I'll start with this slide, which is a greeting slide to all of you from Mayo Clinic up in Rochester, Minnesota, to this very innovative, exciting conference, from endothelium to balloon through cardiovascular imaging. Imaging is the core here for diagnosis, earliest diagnosis, and then to lead to treatment. The only thing that is different here between Professor Braunwald's presentation and mine is Dr. Modena allowed 25 minutes for his presentation and 2 hours for my presentation. So it's a very hard act to follow, Professor Braunwald, who has fantastic achievements that you all heard, fantastic presenter, and our heartiest congratulations to Eugene for this great honor, and of course we are his students as well, so it's wonderful to be present with Professor Braunwald in this opening lecture. Let me just start with this first slide. A very simple slide, shows multiple events. There is Mount Everest, there is open heart-lung machine, there's a microwave, there is the favorite American car Corvette, DNA, and ECG showing Osborne wave, and the jello pudding. And the question is, what do these images have in common with echocardiography? The answer, I think most of you know, lies that in these all share the year 1953, when all these important events occurred. The structure of DNA was described and echocardiography was conceived. And of course 2 years ago, 50th anniversary was celebrated with a lot of fantastic celebrations throughout the world, and we'll talk a little bit about that. These are the pioneers that you heard about. Drs. Edler and Drs. Hertz, a physicist and a physician combination, resulting in this fantastic modality we call echocardiography. On this particular event in 2003 at Mayo Clinic, we also held a symposium where you'll see some important personalities here. This is Dr. Claude Joyner, who introduced echocardiography in the United States 1960. Of course, Dr. Braunwald in 1963 took that modality echocardiography and made it what it is through his major efforts. In the back row here is Dr. Schattenberg, who introduced echocardiography at the Mayo Clinic. And you have other pioneers from Europe, Roland and Erbel, from Japan, Yoshikawa. Here is Randy Martin, past president of the American Society of Echocardiography. Dr. O. and Miller are the current directors of the Echo Lab at Mayo Clinic. And here is the great Dr. Seward himself that you'll be hearing from him. Many individuals from different parts of the world contributed to development of echocardiography. And we're just covering the past with images here. Some of these faces will be very, very familiar to you, and some may not be, but you see a collage of individuals, physicians, physicists, engineers, sonographers, nurses, students, cardiologists, all combination have worked in all continents of the world to lead to where we are today, 50 plus years later, where echocardiography has become a very important tool in cardiovascular medicine. And that has made a major revolution in the practice of cardiology. Day-to-day cardiology has been revolutionized by echocardiography. As this collage is completed, you'll see that echocardiography has been unlocking the mysteries of the heart over the many years. It is regarded as the heart of cardiology, and without it, cardiology practice will be suboptimal and incomplete. So 2 years ago at this particular presentation, I think the statement was made, which is true today as it was then, that echocardiography, because it has high spatial and temporal resolution, and importantly, it has withstood the test of time. Therefore, echocardiography can be rightly considered the current gold standard for assessment of cardiac morphology, function, and hemodynamics at rest and even with exercise, and it's a real-time, immediate feedback modality, hence its importance in day-to-day practice of cardiology. But the beginnings of echocardiography were very humble. This is the paper that truly revolutionized or introduced a revolution, and that was non-invasive detection of pericardial effusion by echocardiography, paper by Harvey Feigenbaum. And these squiggly lines were published. A controlled normal situation, and with introduction of fluid in the pericardial space, this echo-free space was noted between the left ventricular posterior wall echo, that little squiggly line, and the pericardium. Very few people thought echocardiography will go anywhere because of these squiggly, very difficult lines to interpret. But to non-invasively diagnose pericardial effusion was a big breakthrough at that time. Now, just a quick journey, a review that Dr. Braunwald has already mentioned. Let me take you back into history a little bit, the beginning of cardiology or physiology, finding the 1628, circulation was described by William Harvey, then stethoscope discovered, X-ray was then discovered by Rankin, Einthoven, you have already heard, who received Nobel Prize for his discovery of ECG, Krotokoff for blood pressure measurement, and then self-catheterization, Forsman, followed by clinical cardiac catheterization, Cronan and Richards, who also received Nobel Prize. Ultrasound came into being after this disaster. Titanic disaster took place, sonar was produced, and finally released for general use when it was then used in 1953 in Sweden, Lund, Sweden, by Drs. Adler and physicist Hertz combination in 1953 to produce what we know today. They planted the seed of echocardiography. This is the original echo machine, and the seed is an acorn that was planted in 1953, and initially it was the evolution in the form of M mode, B mode, squiggly lines that you see here, very familiar to only few people, but it was the revolution with 2D echo that showed tomographic images resembling actual cardiac anatomy that led to acceptance and widespread use of echocardiography. And then this acorn grew into a mighty oak tree in the last 50 years with very important branches: 3D echo, contrast echocardiography, strain and stress imaging, and non-invasive determination of cardiac hemodynamics. Remember, up until this time, no one could even imagine that one could obtain detailed hemodynamic information non-invasively. That is a territory for cardiac catheterization that Cournand, Richards, and Forsman had invented and popularized, and for which a Nobel Prize was received. But now in the last 20 plus years, using simple equations, principles, Bernoulli equation, hydraulic formula for flow calculation, PISA methodology based on flow acceleration, and continuity equation based on law of conservation of mass. Using these simple principles, we can be able to derive detailed hemodynamics non-invasively, measurement of stroke volume and cardiac output, intracardiac pressures, a good assessment of diastolic function, a precise assessment of valvular stenosis, aortic and mitral, pulmonary and tricuspid, quantitative assessment of valvular regurgitation and shunt quantitation. So much so that for aortic stenosis, as an example, the hemodynamic cardiac catheterization has been now reduced at majority of centers worldwide to less than 10%, in most centers 5% of the cases only. A dramatic change in the practice of cardiology has taken place. Let me spend a few minutes on another very important area, namely quantitative assessment of valvular regurgitation. Regurgitant volume and effective regurgitant orifice area are routinely being measured in our and many other laboratories in patients with valve regurgitation. The importance of this lies in prognostication, because no longer we should be satisfied with semi-quantitative assessment of valve regurgitation. This is the schema approved by the American Society of Echo of how to grade severity of valve regurgitation, in this case mitral regurgitation, in an organic lesion, myxomatous valve disease leading to regurgitation. Regurgitant orifice area less than 0.2 centimeters square is considered mild regurgitation, 0.4 centimeters square or greater, severe regurgitation. Importance in prognostication based on quantitation was recently published by our group in this journal about 6 months ago, looking at a subgroup of patients that have been serially studied who were asymptomatic at the time of this quantitative assessment. 456 patients, mean age 63, majority males with normal ejection fraction. Note that the 5-year survival was predicted based on the severity of valve regurgitation. Orifice area equal to 0.4 centimeter square or 40 millimeter square or greater, shown in green curve. Very high mortality rate in the next 5 years. Lowest mortality as expected for mild, shown in yellow. But please note, those patients who started with intermediate severity, orifice area between 20 to 39 millimeters for the first few years, had excellent prognosis, and then because mitral regurgitation begets mitral regurgitation, they had worsening of their severity and worse prognosis and survival noted. So this study underscores the value of quantitative assessment of regurgitation, and not only mortality but morbid events are also very clearly predicted by this type of semi-quantitative, this type of quantitative assessment of valve regurgitation. Now I show this slide. I'm in the land of Michelangelo. You all know and seen David's beautiful sculpture. What does this have to do with echocardiography? The reason I show this is that a lot of individuals have referred to echocardiography being like a David in the land of Goliaths. Now we have a lot of Goliaths, and this may be more appropriate presentation of echocardiography here facing a Goliath there. And Goliaths, as you know, are big, heavy, heavily armored, expensive, and so forth, and that could be cardiac catheterization laboratory doing hemodynamic assessment. And what is small about echocardiography is this footprint has a small stature, but the information content it has derived and given us for management of patients is immense. Hence, echocardiography right now, with using Doppler methodology, has replaced the invasive, have supplanted the invasive hemodynamics in vast majority of patients for both left and right heart hemodynamics. Now let me just say a few words about this mighty oak tree where we are, all these fantastic important branches. Of course we don't have any time to discuss them in detail. I'll say a few words about another very exciting area that is developing still in its infancy, and that is the area of visualizing cardiac anatomy in real time, 3D and 4D. And here you can see an example of a large tumor in the posterolateral wall of left ventricle being seen in a three-dimensional display, and you can readily see the size, extent, and involvement of this tumor in that area. Let me just move on to show you an example of mitral valve, myxomatous valve disease with prolapse of the anterior leaflet, and from this 3D image you can then easily derive unidimensional studies, a two-dimensional format, and see it in different planes. The next one will show you an example of hypertrophic left ventricle in a patient with combined hypertrophic cardiomyopathy and moderate calcific aortic valve disease. And you can see this very vividly, including a very large left atrium, which is reflecting or indicating associated diastolic dysfunction as well as mitral regurgitation. And lastly, an example of mitral stenosis with markedly tethered subvalvular apparatus, which is very beautifully seen in this three-dimensional display with dilated left atrium. As I mentioned, it's in its infancy, but it is an exciting development and more to be seen in this regard. Now we'll go on to see what is happening next in the field of echocardiography. The mighty oak tree has bloomed and grown, but giving off multiple acorns are dropping all the time. A lot of developments are happening, some in their real infancy, some are maturing a little more so, and I will just concentrate here on one such development, which to me is very, very exciting development, and that's shown on this cartoon where you could see the morphing of the big machine into small, and the other big development is in the invasive field of an ultrasound catheter which is equipped with the ultrasound power developed by Siemens Corporation now and called EcuNav, and that's another very exciting development. Let's look at how the technology has developed. Ultrasound technology, cost versus its size versus diagnostic ability. And in this year and beyond, you can see more complex development in the form of 4D, in the form of parametric imaging, and less complex, more handy development where you can disseminate this powerful ultrasound technology. And this is what has happened in the last 25 years. Big machines, 400-pound gorilla type of machines have been reduced to very small portable 20-pound units, and more recently into handheld, hand-carried 5-pound units, which are shown here. And let me just move on. They are less than 5 pounds, very portable, and they have very diagnostic quality images as you see here, and they are beautiful units for screening and answering focused questions such as what is patient's LV function, are there any wall motion abnormalities present, is there any pericardial effusion, what are the valves like, other masses and so forth, and one can readily screen abdominal aorta for silent abdominal aortic aneurysms and also use it to guide interventions. So this is an important development, and here's my colleague Dr. Chandra taking the machine at the bedside. In coronary care unit, it can be done in medical intensive care, surgical intensive care, emergency room. So you can see that we now have a very powerful modality that needs to be and must be disseminated beyond cardiologists. And we need to train. It creates another very important challenge, but it has to go beyond cardiologists to internists, surgeons, to the ER physicians, and we have introduced it in our medical school classes, teaching them to become proficient with the use of ultrasound, as for years we've been teaching them to become proficient with the use of sound using stethoscope. With ultrasound, you're more precise, you're more accurate, you're more efficient with immediate feedback of the diagnosis. So clearly, we are embarking on the next big revolution in medicine, and that is a ultrasound stethoscope, a sonoscope, or whatever it will be finally called. It will be hanging in the pockets of physicians who will make more accurate and timely diagnosis of patients with various types of cardiovascular disorders right at the bedside. Small size has made it feasible to have echo on Everest, where pulmonary hypertension studies have been going on by various investigators, and even it has permitted it to go in the space where a small equipment like this has been very useful to study the cardiovascular system of astronauts. Now a few words about the future direction of echo. This was the present. And we must keep in mind this particular slide, that when we start imaging, we do whole organ imaging. When we get sophisticated, we do individual part imaging, going down, drilling down to the tissue level, cell metabolism, molecular imaging, and back to developing a total understanding of the whole organ, intact organ. So this is very important, and echocardiography is moving from the whole organ imaging into its parts and into the cellular molecular level. I quote here the pioneer of Mayo, who says, I looked through, let me just go back to this slide. It's an important vision of the pioneer of Mayo Clinic, one of the brothers, who says that I looked through a half-open door into the future, full of interest, intriguing beyond my power to describe. And that's how one feels looking at the future of echocardiography. There's going to be live, high-quality 3D, 4D imaging. Fantastic advance will be there. Heading towards molecular imaging, using ultrasound for therapeutic purposes, parametric imaging. And we've talked about handheld echo, we've briefly referred to miniaturization, intracardiac echo, and so forth. Here is a parametric simple image that Dr. Seward was involved in several years ago. The green color shows area of hypokinesis. You can immediately see in this parametric image that on the left is the anteroseptal apical infarction, and that area is all green, hypokinetic. And on the right is an example of diffusely hypokinetic LV from a patient with cardiomyopathy. So this simple color-coded parametric image is extremely important and has important content, information content. Here's a strain rate image of an inferior wall, posterior wall infarct. We are heading towards molecular medicine. There's a revolution afoot here. Now with the nuclear techniques, lot of advances have been done, but MRI, CTs, and ultrasound are moving in the same direction. Basis is that the clinician and scientists develop the ideas, provide direction, ultrasound manufacturer, equipment manufacturers give us the appropriate tools, high imaging modalities, and then pharmaceutical companies. Here is the important bonding and working together of academics, industries, both manufacturers of equipment and pharmaceuticals in combination to take us to the next frontier. This is work from Dr. Sanjeev Kaul's laboratory, imaging WBCs, leukocytes, in an infarcted portion of the left ventricle. You can see with contrast echo that area becomes beautifully outlined in a patient with the septal infarction and in a patient with lateral wall infarction, as shown with these other techniques, proven with the techniques that are shown on the side. So imaging of leukocytes with contrast echo. This is ongoing works in progress from Drs. Vannon and Verjans in the laboratory of Dr. Narula, where they are interested in using microbubbles, specialized constructed ones, for studying apoptosis of the heart. And this is another works in progress showing how contrast echo can be utilized for such modality. Therapeutic ultrasound, there's some progress being made, and future looks very interesting and very exciting to me in this area, because using the bubble technology, genes and transfection can be enhanced, and this work has been well demonstrated now from different laboratories. Using high-intensity focused ultrasound, arrhythmia ablation is feasible and being done in select centers now. Also, there are specialized ultrasound equipments using this modality for resulting in coagulation during surgery, closing arterial punctures during catheterization and so forth. And of course, thrombolysis has been enhanced using specialized ultrasound insonation and so forth. Now, challenges for ultrasound are many and upon us, and we see here one important challenge that is facing echocardiography, and that is cardiac MRI. Cardiac MRI, and here's Dr. Randy Martin in an MRI suite, showing, of course, a portable ultrasound against a big stationary unit, which is the MRI unit. And we can again visualize it in this form, that we have a very powerful, expensive, stationary modality against a very small, nimble modality, which is echocardiography, proven its time. Let me show you an image here. Now this is an echo image from one of my patients with a mid-ventricular obstruction of left ventricle, apical dyskinetic pouch, a subform of hypertrophic cardiomyopathy. Diagnosis clearly made by echocardiography. We are doing routine studies with MRI to understand the value, and so forth of MRI in this entity. And here is the MRI of this patient, and you all will agree that the MRI picture is far beautiful. Clearly shows the mid-ventricular hypertrophy and in systole obstruction and the thinned apex dyskinetic pouch. Now, we all know that beautiful pictures are provided by MRI, but we should remember that pretty pictures do not make a gold standard. I like to emphasize this point because in the next 2 days we will be hearing a lot about latest in technologies and what their value is. What is important when we compare different modalities is pretty pictures alone do not make a gold standard. It is the incremental value and the test of time, standing the cruel test of time, that finally will establish a modality for the gold standard. In this patient with apical mid-ventricular obstruction, what is the incremental value from MR study was delayed hyper-enhancement of the apex. You can see that beautifully here. Scar. That's the incremental information that one cannot get from echocardiography. Here are 2 examples from different patients with hypertrophic cardiomyopathy. Both have undergone a procedure. On your left, patient had alcohol septal ablation. Please note on the MRI examination there's a large septal scar. On the right is another patient who has undergone surgery for hypertrophic obstructive cardiomyopathy, absence of scar on CMR delayed hyper-enhancement study. This is incremental information, and this is what is so important in analyzing the importance of these new modalities. CMR, cardiac MR, has to wait and go through the cruel test of time over the next, I would believe, 10 years before we can come and say that's become the gold standard. Lastly, it is the multi-slice CT that will be discussed again in this conference in detail. Its incremental value is very clear. It provides something that echocardiography cannot provide, and that is non-invasive visualization of the coronary tree. As long as we concentrate on this type of images from the multi-slice CT that is incremental, the bottom part is redundant because we do not need contrast injection to evaluate left ventricular size, mass, function, so forth, which is done beautifully by echocardiography. This is the incremental value of multi-slice CT, detection of non-calcified plaque. What we have facing us right now in echocardiography is a big challenge about maintaining its quality. And American Society of Echocardiography has committed itself to champion creating an environment for excellence in quality and practice of cardiovascular ultrasound by newsletters, quality-based reimbursement, promoting that, credentialing, and publishing best practice guidelines. Standing for the quality is a must in everybody's practice for any modality, but it is even more so for echocardiography these days because it's being disseminated and quality is being eroded. Continuous training, continuous quality improvement, credentialing, accreditation, quality-based reimbursements are all part of keeping and promoting quality. and ASC and all of us concerned with that are very committed to that. American Society of Echocardiography is so much committed to training that they have launched a whole program of training the new generation of echocardiographers in utero. This is a nice slide showing how the next generation of echocardiographers will be coming prepared to do the battles. But let me summarize what I have been saying with a quote from our very distinguished professor here, Professor Braunwald. Echocardiography ranks with open heart surgery as the most important breakthrough in cardiology in the past 4 decades. He was quoted to have said this on the 25th anniversary of echocardiography in the United States at Dr. Feigenbaum's symposium. And in my 35 years career with echocardiography, I will say something like this, that echocardiography is the most useful diagnostic tool in cardiology practice devised to date, and that I see being the case for the foreseeable future. We have witnessed the golden anniversary of echocardiography. It's been a fantastic journey. We are in it. It is the most important technology for our patients and their care. And now we are proceeding towards the next era, which is the golden era. From golden era is to the platinum era. And that is where I see ourselves heading because of the bright, bright future for echocardiography that is upon us. So may the force of echo, quoting this very famous line, be with all of you, and I thank you for this invitation and your attention.